Good afternoon, everyone, and thank you for joining us today for MHPA's Webinar Wednesday series. My name is Patrick Kaur, and I'm MHPA's Senior Director of Membership and Partnership Engagement. I'd like to take one moment to provide a brief introduction for today's webinar. Just a couple of quick housekeeping items to start. The presentation is in listen-only mode. If you have any questions throughout the webinar, please enter them using the Q&A button located at the bottom of your screen. Please avoid using the chat feature for questions and use the Q&A button instead so we can get to as many questions as possible. If you are interested in today's slides, Papa will be including them in their follow-up communication. If you have any questions until then, please feel free to reach out. We'll also have them on MHPA's YouTube channel. Okay. Now I'm excited to welcome and introduce our presenters this afternoon, Dr. Kay Judge of Meridian of Michigan and Dr. Ellen Rudy of Papa. Dr. Kay Judge has been a physician leader with the Fortune 50 Managed Care Health Plan Centene for over 3 years. Initially with HealthNet in California, and now as the CMO of Meridian, has over 2 decades of experience from large health systems and insurance industry in Michigan and California. She has a passion for health equity and her career is focused on innovation and reducing longstanding disparities in healthcare. The Detroit native attended Wayne State University School of Medicine, received her Master of Health Administration degree from the University of Southern California. Prior to joining Centene, Dr. Judge served as a senior staff physician in internal medicine at Henry Ford Hospital in Detroit. She later served as a physician executive in the Sutter Health System in Sacramento, California, and was on the board of directors, as well as headed Medicare Advantage, integrative medicine, and bariatric medicine service lines. Dr. Judge brings a wide range of expertise to Meridian, including experience coordinating data analytics, digital therapeutics, and remote technologies in population health and care management in the post-COVID-19 era. She is an author and nationally recognized public speaker and is on the board of directors for a 3,000-member physician nonprofit group SOAR, which focuses on reducing health disparities through education and advocacy. Meridian, founded in 1997, is the largest Medicaid managed care plan in Michigan and serves more than 500,000 Medicaid, Medicare plan, DMP, and marketplace members throughout the state. Dr. Ellen Rudy serves as the Vice President of Health and Social Impact at Papa, with the responsibility to evaluate Papa's impact on members' quality of life, health outcomes, and total cost of care. Dr. Rudy earned her PhD in epidemiology from the University of California, Los Angeles, and completed her postdoctoral fellowship in health policy and research at Rand and UCLA. She most recently worked at Molina Healthcare, also an MHPA member, a managed care organization providing Medicaid, Medicare healthcare services with leadership responsibilities across the population, health management, health policy, research, quality, and healthcare operations. She currently serves as an expert faculty member at the University of Southern California Sol Price School of Public Policy. Dr. Kay and Dr. Rudy will be presenting today's webinar, Reducing SDoH Disparities in Medicaid with Social Support Solutions. And with more than a few hundred registered attendees, we're very excited. This is one of our most well-attended webinars ever from HPA's Webinar Wednesday. So with that said, I'm very excited to turn things over to Dr. Rudy and Dr. Kay.
Thank you so much, Patrick and Medicaid Health Plans of America, for the intro and this exciting opportunity to speak. I'd also like to thank Dr. Rudy and Papa for their partnership in this very exciting SDoH experiment we're going to be talking about. And most of all, I do want to thank all of you on the call who are giving us the gift of your time and interest. We look forward to spending the next hour with all of you. Dr. Rudy?
Thank you. And thank you, Dr. Judge, for participating as well. I really appreciate talking about this really important topic. So what I'm going to do is I'm going to tee this up by talking a little bit about social drivers of health, what populations can benefit from social support, a little bit about Papa, and then pass it back to Dr. Judge, who will talk about some of the results and her experience with Papa and some of the key takeaways. Okay. So first I wanted to sort of talk to the audience about what does it mean to be low income? So for a family of four who is just above the poverty level, their monthly income is $3,000 a month. So to put that into perspective, the average price of a one-bedroom apartment rent per month is $1,700 in the United States right now. For a two-bedroom, it's $2,100. The budget, the average budget for a family of four, a low budget for groceries is $900 per month. Utilities right now cost $366 a month. So what you see when you add it up, there's not really much left to pay for things like transportation, gas, internet, phones, and let alone, tutoring for your kids. So you can see, low income people, they're struggling just to meet basic life necessities. So, health and health behaviors doesn't become their priority. And as such, low income people, they have lower cancer screenings, higher infant mortality rates, and they have higher death rates for the 14 leading causes of death in the United States. And even new deaths introduced to, or new diseases introduced into our society, HIV and COVID, in the beginning, they actually impact both the rich and poor the same. But eventually what happens is they end up impacting the poor more. So why is that? Well, it really has to do with the social drivers of health. This is where you're born, where you grow up, where you live, what schools you have, what's your generational wealth, your neighborhood. All of that is what really drives the health disparities that we see today. For example, your parents' education level actually predicted your education level by age 19 and also predicted your financial success at age 48. And so, some of the social drivers that, they have taken decades to really impact the health disparities we see, and it will take time and resources to reverse that. I know that. But there are things we can do right now. There are more immediate things we can do that we can see a more immediate impact on reducing the health disparities. And here at Papa, we're really interested in looking at how does social support influence each of these social drivers? And so what I'm going to do is then kind of taking the lens of social support, look at examples of when you don't have social support and when you do have social support, and how that influences the social drivers and subsequently the health outcomes. So access to healthcare quality. I like to more think of it as barriers to access to healthcare quality. 75% of chronic diseases are preventable. Not going to the doctor for routine care is preventable. Not getting timely prenatal care is absolutely preventable. When I was in my days in Medicaid, we used to come across every so often a woman who was pregnant, who was in her third trimester, and she still didn't have prenatal care. And, finding that one time is one time too many. And so then my team would have to go and search to find an OB, a doctor who would take her on. It's already hard enough to find specialists that take on Medicaid patients, but now you add a high-risk patient on top of it. And so eventually we would find a doctor, but it could be 15 miles away. It could be across the county line. And so now there's a transportation barrier. And then finally, I always think, well, how does this woman feel when she goes to the doctor? Does she feel judged? Does she feel discriminated against? And so there's barriers in not having usual care, so you don't know the importance of preventive care, transportation barriers, and really feelings of perceived discrimination. All of that influences your access to healthcare. And so imagine if you had somebody to be with you, an advocate, somebody that not only drove you to the doctor, but actually went into the office with you and sat with you and waited in the waiting room. Somebody that's on your side. I mean, that can really make the difference in the health outcomes. And then people who are socially isolated are 6 times more likely to go to the emergency room. A lot of people who are truly socially isolated have had a lot of trauma in their past. They also, they don't have the patterns of routine care. So they are used to having crisis-driven, fear-based care going to the emergency room. But when you introduce somebody who can sort of have that human connection, you can revert that and have people go to the office visits, a regular doctor instead. And then location matters. So we already know about food deserts. There was just an article written about pharmacy deserts that exists too. We have a gentleman who is a DSNP member. He's both Medicare and Medicaid. And every week his pal meets him at his home. And this gentleman has all the errands, all the social errands, the non-clinical errands he needs to get done. So he has the pal take him to the bank, and then he goes to the pharmacy. He gets picks up a COVID test there. Then he goes to the grocery store, because where he lives is a food desert. The closest, food source is like a 7-Eleven. So think about, what if that gentleman doesn't have that person, that social support to help him with the non-clinical needs. And education, absolutely is a huge driver of health outcomes. But we think about what is one of the downstream consequences of low education attainment is actually low health literacy. And so oftentimes people who often have low health literacy, they're new to the healthcare system. Maybe they didn't have insurance before. They don't know how to, navigate the healthcare system, make appointments, change appointments, make sure that they have a regular PCP. At Papa, we get lots and lots of phone calls and pals receiving questions about, I don't know how to use my benefits. I don't know how to change appointments. This is a real issue, and it really does low health literacy prevents good health behavior. And then finally, economic stability. I mean, economic instability is really the engine behind most of the social drivers of health. What we find also is a lot of the economic instability is hidden. So for example, Pal went to a home of a member and went to turn the lights on, and the lights didn't turn on because the member's son who we lived with lost his job. And so they didn't pay for the utilities. And then they also couldn't pay the rent. So this gentleman was going to be evicted that very weekend. I mean, this was an incredibly escalated situation, and the PAL escalated to our social care navigation team, who helped find this gentleman, some temporary housing. But the key was, nobody really knew about it. It was hidden. And if the PAL didn't intervene, he could have been homeless. So now I take a step back and I say, what are the populations that actually can benefit from social support? What are the populations that are impacted by these social drivers? So people of color, unfortunately, in America still have a disproportionate share of health disparities. Less likely to have their babies fully immunized. African-American women are 40% more likely to have preterm births. And in our data, what we found in some of our survey, that they're also 200% more likely to say they have no social support, nobody to help them, with just those basic non-clinical needs. And so you add that on top of the other social drivers, and it just exacerbates the health disparities. High ED utilizers, the super users, again, these are people who do not have a human connection. They're socially isolated. They've had some trauma in the past. So if you provide them with a PAL, we've seen actually a 34% reduction in members becoming super users just by having that connection. And then women and children, they are some of the most vulnerable population in the world. Low-income children are 15 points less likely on average to get a well child visit compared to high-income children. And why is that important? Well, for one reason, it's at the well child visit is where you get your developmental screenings. And if you are missing your well child visits, then you're missing the ability to identify maybe something, a developmental delay. So you can then, put that child on get them the resources, put them on the right care plan. So all three of these populations can benefit from social support. All three of these populations can benefit from having somebody like a PAL, having human connection, a trusted resource to actually help them navigate, the healthcare system and help them get to their appointments and help them with all the non-clinical needs. So loneliness is universal. In our data, 53% of Papa's Medicare members are lonely. And actually 41% of our Medicaid members are lonely, which is still really high. And we demonstrated in the Medicare population that we can reduce loneliness, that we can reduce emergency department visits by creating this human connection. And now we are demonstrating that we can do the same thing, that this program works in Medicaid as well. So Papa really is a new category of care. It's providing companionship. It's providing assistance with everyday needs, the non-clinical help. A lot of times people may have access to transportation to doctors, but they don't have access to transportation to the grocery store, into the pharmacy, into other social events, to the WIC center. So in the PALS, we have a tech-enabled platform. It matches older adults and families with Papa PALS. And Papa PALS are empathetic lay people. They are people who are looking for flexible and meaningful work. College students, stay-at-home mom and dads, empty nesters. There's a lot of people who really like this type of work. And we have created a platform to connect these PALs to members. And it's amazing. We have this national scalable network of PALs. And the beauty is we are able to scale this up. We can be in every state. We can be in every county. And this year alone, we've actually provided 1.5 million hours of social support. We partner with Medicare plans and Medicaid plans like Meridian. And I'm just really excited to pass this over to Dr. Judge, who's going to talk about her experience with Papa, some really amazing results, and some key takeaways.
Thank you, Dr. Rudy. It's riveting, and thank you for your passion for social determinants of health and the vulnerable. So Meridian, giving the health plan perspective, just a little insight into Meridian. We are a government-sponsored health plan in Michigan. We serve over 600,000 members. 500,000 of our members are on Medicaid. So the vulnerable are not an afterthought. The vulnerable are what we take care of in Michigan. As a health plan, when we're looking at population health, we're looking at various factors, and Dr. Rudy laid out the social determinants of health. And from our perspective, I absolutely agree. These are the ones that are shining through as impacting the health of our members. They are poverty, they're discrimination, quality housing, transportation, safe environments, food, access to healthcare. So in the past, maybe 20 years ago, I think that health equity was something on the back of our mind, where we think, okay, we're going to keep everything in mind and take care of our members. And I think the evolution over the last decade or so has become more and more forefront, where, as a physician, it's important for me to know, does a patient have diabetes? Do they have hypertension? Do they have coronary artery disease? But is it just as important for me as a physician, and as a physician who's passionate about bringing health equity on behalf of a health plan, is it just as important for me to know other things about my members that will be impacting their health, about 80% of what they bring to the table? And that'll be their race, their education, their income, sexual orientation, the Black trans woman in America is the most medically vulnerable in the United States. We should know that as we're taking care of our members. Geographic location, where you live, your zip code determines how long you're going to live by 7 to 15 years. Your mental health, your physical cognitive abilities. So we embarked on this with enthusiasm and passion of what can we do to start chipping away at some of these, address this not from the problem, the symptom, which is ill health, but maybe the problem, which is loneliness that's coming from behind the disease state. Next slide. So as we looked at our data, I think data collation for a health plan is difficult, especially social determinants of health and especially self-reported social determinants of health. So we're still, as a health plan, struggling to get comprehensive data. So we're looking at various data sources and compiling them. But just as an overview, we saw at least 12% of our members with SDoH needs had anxiety, stress, or depression. Housing is one of our biggest needs in the Medicaid population. Black Americans are Native Americans 2 to 4 times more likely to have SDoH than their white counterparts, as Dr. Rudy also mentioned. Next slide. So we then partnered in with Papa on what this would look like if we just focused on social isolation. We did it kind of uniquely. We presumed social isolation would be a problem. We looked at utilization as a metric for our cohort that we looked at. And what we did is we looked at members who were 45 years or over, who've had 5 or more ED visits a year, and we linked them with our community members and Papa Pals. And as Dr. Rudy mentioned, I think on loneliness, just other data that for me feels compelling as an internist is that according to the National Academies of Sciences, Engineering, and Medicine, more than 1/3 of adults 45 and older report feeling lonely, but also social isolation is linked to a 50% increased risk of dementia. People literally are getting Alzheimer's faster, more if they're socially isolated. It is a 30% increased risk of heart disease, a 32% increased risk of stroke. So loneliness is killing people. And loneliness and everything else that entails is literally killing people. So we took our members, we got a cohort of 160 members, and we connected them with Papa Pals who addressed their social and clinical needs, who gave that proactive support that Dr. Rudy was talking about. And then we stepped back and tried to see what is this ROI in what we've attempted to accomplish. And this particular endeavor, actually on the bottom, the Michigan Association of Health Plans gave us the Pinnacle Award winner in Collaborative Community Health Initiatives to Papa and Meridian, and we're very proud of that acknowledgement. I think that's right back there. One of the medals that we received. Next page, next slide. So here's the data, and if for anybody who tracks REIs, this is so statistically significant. What we did is we looked at claims data 6 months pre and post enrollment to see what are the differences in utilization. We found a 25% decrease in ED visits, and it's actually more of a 36% decrease in healthcare costs, not 33, as we're getting the data together, and a 14% decrease in hospital readmissions for the members who were engaged in this program. The level of engagement is, as Dr. Rudy said, multiple points of contact for our members. Out of the 163 members that we had, there were about 719 visits with the Papa Pals, and 806 tests were completed in that time period. Next slide. And in terms of, so we talked about utilization, and I think let's look at the quadruple aim. How is it helping our members overall? It also positively, proactively improved the quality. What we noticed was a 50% increase in cervical cancer screenings, a 46% increase in diabetic eye exams, and a 35% increase in hemoglobin A1C testing. And what I didn't add here, which I find increased just as compelling as an internist, is measures that are very difficult to control, like controlling high blood pressure. We also noticed a significant increase in control of 8 to 9%. And that's pretty compelling because it's easy to get someone to go and get their cervical cancer screening. It's harder to get them to take their medication, to eat the right things, to see their doctor enough that they're not popping in the ER and their blood pressure has gone down. So those metrics actually show that we are impacting the health of our member lives in meaningful ways. Next slide. So, I mean, I think that this is a lovely experiment, I think, in just really bringing home the point of, I think we all know in the back of our minds, health equity is a problem. We think that looking at social determinants of health may be part of a solution. I think that here's a metric-driven small pilot that we now intend to expand within Meridian to see, you know, how can we positively, proactively look at these drivers of health, social determinants to positively impact them. In this particular case, this was a partnership with Papa, which showed that the social support program that addresses social determinants of health can impact healthcare utilization. And this was made possible by, as the slide shows, the power of the human connection.
Yeah, and just to add, you know, I think that just the results are so exciting. I mean, I was so excited to see the results because I think as researchers and as an internist, you know, you've always seen that it's the social connection, the human connection that can really drive people to take better care for themselves and also help with the fact that some people have nobody. And it's, you know, sometimes that's hard to think about when you're perhaps surrounded by family, but there's a lot of people who don't have that and they don't have somebody to take them to the grocery store. So I just think just seeing Papa as, you know, providing companionship and providing compassion, providing trust, you know, really makes the difference. You know, my first job was in a safety net clinic in Hollywood, and it was a place that was safe for a lot of people to come. And I could see that just when they had the trust of somebody, they would do things, they would change their behavior. And now to see, you know, an organization like Papa that scaled it, it's just amazing.
Absolutely.
So just to tell a couple stories. So Felicia got COVID. And when she got COVID, she was she got long COVID, and it really was debilitating. And her health plan, Meridian, called to offer Papa to her to help her take her to her doctors because she had a lot of doctor's visits and she didn't have transportation. Unfortunately, the symptoms of long COVID actually created it actually really difficult for her to keep her job because she had such debilitating symptoms, and she lost her job, which also spiraled to depression. But her pal actually said, you know, Felicia, you actually have such a incredible personality. You engender trust. You have a beautiful smile. You should become a pal. And actually Felicia did. And she absolutely loves it. And not only that, but it gave her flexible work. It gave her employment again so that she wouldn't just be in a cycle of poverty. And it really gave her such meaning because now she's helping other people as well.
It's a lovely story. And I agree, you know, at Meridian, we feel our member stories are the reason why we do what we do. Lacey is another story. Lacey is a single mother of 4. She was skeptical when she was first told of Papa. She did decide to give it a try. She met her Papa pal, who was Michelle. Michelle was lonely. She has a grown child in California. Her parents and brothers had passed away, and she retired on disability and was looking for something to do. Michelle now helps Lacey care for her children. She takes Lacey to the food bank. She helped her during her last pregnancy. Michelle didn't expect to find a mutually beneficial relationship, but that's what she ended up getting with this partnership. The pair have become now each other's unofficial social support system and chosen family. And Michelle has said, because of Lacey, I don't feel so alone. She and her children are my chosen family.
Such a great story. So some key takeaways. Well, for us, at Papa, social support is just a core component that can really change people's health trajectories. We've seen it in the results you see today, and we're just really excited about health plans like Meridian that are willing to invest in a program like Papa. They're willing to actually tackle loneliness, social isolation, unmet clinical needs with a program like Papa. And I think what's also encouraging is that the federal government is also paying attention. And it's so amazing to see that the discussion has gotten finally all the way to the top. And you can see that in some of the things they're doing. For instance, they have a health equity pathway. And so one of the things that they're starting to require is to actually look at the data stratified by race, ethnicity. And that's really important. You gotta start by looking at the data and seeing who has these health disparities and how are you going to attack it. And they're starting to require social needs screening. And what do you do when you identify positive social needs screening? And so I think what's also really a great takeaway is, investing in the future, not just in the 1-year future, but in the 3-year future, because some of this, like I said, some of these social determinants of health and the health disparity, they don't change in 1 year, and so it's so encouraging to see a plan like Meridian who's willing to invest, because it is going to be a multi-year, project or program. And also by doing that, you as an innovative health plan are going to be ahead of the game, because this has become more and more important all the way up at the state and federal level.
Absolutely, Dr. Rudy. Everything you said, my key takeaways, and I'll expound on what you just said. I think just that for me, the 30,000-foot view and the passion, I'm sure for all of you who are on the phone call, is just health equity. And the knowledge for me that we cannot achieve health equity without this deep dive into structural issues and structural solutions. I think for me, there's a humility and an awe, kind of an overwhelm, if you will, but a knowledge that we have to do it, that the persistent health inequities in our country are unacceptable. They're unacceptable. There's no reason why Black women should be dying at 2 to 4 times the rate of white women, with all other socioeconomic factors being attributed for in childbirth. So these persistent health inequities are unacceptable and correctable, and we are all part of that solution. I think another thing that strikes me when we look at something like this is that some individuals and groups need an extra boost to reach these equal outcomes. So what is that equalizer here? The equalizer is give something that helps correct these social determinants of health. In this case, it was a companion. And I think like my final kind of inspirational call to action charge for all of us is that it is incumbent upon all of us to break our siloed thinking, our stasis, and get a partner in innovative solutions. It's incumbent on all of us to dismantle structural systems that are perpetuating these health inequities. And it is incumbent on all of us to kick down barriers to create better health for all. Thank you.
Thank you. So well said.
Wow, 15 questions. Patrick, off to you.
Wow.
Thank you. Yeah, well, it just goes to how important this topic is, and that was a great presentation. I think these questions are wonderful. So without delay, let's go ahead and introduce Jessica Legg, Vice President of Enterprise Marketing at Papa, to facilitate the Q&A.
Excellent. Thank you so much. So we have some, maybe we'll start off with some of the questions that are very specific to this partnership, Dr. Judge. We have some questions related to why did you pick loneliness as the SDoH that you chose to focus on for this pilot? And was member engagement completing care gaps an incidental finding, or did you expect to find that member engagement would be critical to success?
You know, it's nice to say we have a crystal ball. And I think that I think that the question is, I think that we intuitively know that addressing loneliness with the data, Dr. Rudy and I both presented data that shows loneliness is key to outcomes. We were hoping that if we picked this level of social isolation, which in Medicaid lives, social isolation leads to less access in medical care. It leads to not understanding the availability of medical resources. It leads to not knowing how to fulfill your care gap. So it seemed to be the loneliness was the key to unraveling what we call, and I hate to use the term non-compliance, because for me, it's we haven't reached the member yet at a place they can understand.
Excellent, thank you. A very specific question, but did the project include MLTSS members?
No.
Okay. And then how did you decide who to include in the first cohort? And how many visits on average do you feel like they had?
So we wanted a doable number in a pilot, enough that it was statistically significant, but enough that we could give the time and energy that those member lives did. The rest was our population health pyramid, where, as I said, we looked at our utilization metrics. I think that one of the challenges in the work in health equity is the finances. It's all a good concept until we can show that not only is it good, but it's better for healthcare as a whole. It's better for the finances of healthcare. So from an economic perspective, we looked at utilization and then we backtracked. And it was a matter of looking at the 5 or more, and those members that hit those 5 or more ER visits were the ones we initially concentrated on. The ones who we could reach out of them were the ones that then became the 163 in the cohort.
Thank you. I think that also addressed the question about how you measured reduced costs of care.
Yes.
So let me just see. Dr. Rudy, maybe kind of switching gears a little bit to talk about the Papa Pals themselves. I think this is an interesting question because it comes up quite a bit. Can you explain a little bit the difference between the role Papa Pals play versus community health workers?
Sure. Actually, I would say they're quite similar in some ways. I think they're, the way that the Papa Pal works is that when you become a pal, you can go on your app and you can, press the app and see what appointments are available. And usually, most likely, pretty much most of the time, the pals are going to members who are in their community because they're going to go nearby. And that's part of what a community health worker is. We wanted to make sure that this could be a recurring visit, a recurring meeting. Sometimes community health workers might come 1 or twice or sometimes more, but I think they're very similar, except that the Papa program is scalable. I mean, we can be all over. We can be across the state, we can be up across the country, and we can manage these appointments, which really is an incredible power. I used to work in public health, and when we would have promising interventions, the biggest problem was really being able to deploy it and scale it really widespread.
Excellent. So you mentioned them being out in the community. That was actually another one of the questions that came up was related to the connections between the PALs and the members. The scope of what Papa Pals do, are we addressing or impacting other social drivers of health? Things like housing, et cetera. And do we document any of the SDoH factors that a patient might be experiencing?
Yes, we do. We actually have on our app when a PAL sees something in the home, because that's really that's the secret sauce, is being the eyes and ears in the home. And so when they see a social risk, or sometimes they'll see a clinical risk, like a fall risk, they can just actually, we have buttons that say food insecurity or transportation, and they can just press that, and that goes into our system. And what we have behind, we have a wraparound social care navigation team, and they will receive either these types of escalation, like the example of the housing scenario, and the social care navigators who are trained, they're social workers and nurses. They're the ones who will then follow up with the members to actually connect them to the community-based resources. We have a partnership with Find Help, and that's how we actually connect to the community-based resources. So we do address more than just companionship.
Excellent. We have two actually related questions. One of them is how we reach members and patients that might be in extremely rural areas. And then the second one is related to whether or not we do any virtual support.
Yes, we do reach rural areas. And one of the things about being rural also is sometimes there's not job opportunities. So actually the PAL program actually provides job opportunities for people who do live in rural areas. And then they have to drive farther to meet their members. And then in terms of, what was the next question? I'm sorry.
Whether or not there are virtual visits.
And yes, we do virtual visits as well. In fact, during COVID, Papa flipped like on a dime and turned all their visits to virtual. And actually virtual does have an impact as well. I mean, I would say being in the home is, one of the most powerful things, but checking in with somebody intermittently with phone calls is really powerful as well.
Right. And then on the flip side of that coin, how do you engage members if they maybe don't have access to technology or don't know how to navigate an app? What do those connections look like?
So for the members, we enroll via outbound phone calls. So the members do not have to have technology. In fact, that's one of the things that PALs often work on with members in their home, is how to use their iPad, how to use their telehealth. But the members do not need to, that is not a barrier to using Papa, because it's outbound phone calls, because a lot of times we find that's the easiest way to get in touch with people. And then we connect them, and then PALs are the ones who are using the app.
Right. Dr. Judge, one of the questions that came up is, what are the plans to move the program from a pilot to fully deployed? And, what do we think the long-term vision is here?
I think just looking at principles, I think is a great question. Looking at change management, we start with a pilot and then we just scale out. And when it's successful, just continuing to scale out, continuing to look at cohorts of population, connection points. What we're doing is now we're drilling down on health inequities within our flu shot and our HEDIS, looking at a drill down in counties. And looking at the disparities within races in those counties and coming up with more cohorts that we want to deal with. So I think that this is part of a broader based effort to align, to recognize, identify vulnerable groups, and then align them with solutions like Papa. Do we anticipate challenges in sustaining this program long term? I think it's a great question for those of us in healthcare and managed care. I think we all want to do well for our members. We all want the feel good story, but in the end, it's show me the money, right? We have to show that it fulfills our triple quadruple aim. And in this case, given the fact that there is that ROI in both utilization and in quality, it becomes a no-brainer. In terms of expansion, I think our only challenge here would be how thoughtfully can we scale up and expand and kind of clear some barriers as we go along in connectivity, in data, demographic data collation, and all of that. So yes, this should be fully deployed. Yes, there's going to be challenges, and yes, if there's a thoughtful progress in how we incorporate this should not be something that's impossible to do. thank you for the question.
Dr. Tobin reached out with a very specific question related to data. He mentioned that the income disparity data is convincing, of course. He's interested in hearing from you how data derived from these measures is used to understand and address SDoH and reverse health disparities. He specifically called out the social deprivation index, social vulnerability index, area deprivation index, and local social inequity score, and would love to hear your thoughts on how that data can be leveraged to address SDoH.
So this is a great question to geek out on. And I think there's a lot of, as I had started, there's a lot of factors of social determinants of health that we are now able to quantify in various ways and allocate an acuity index to. There's different acuity indexes depending on which body of science we are reading. But by and large, I think that the ones laid out by Dr. Tobin, social deprivation, social vulnerability, these are tried and true. These absolutely, when we look at the low social inequity score and that significant impact on health, these are those guiding principles of what we look at, knowing this is the known. And this is why, I think there was another wonderful question in here. Why did we choose loneliness? Because loneliness is that tip of the iceberg of these conditions that we're looking at. And so how useful is the data? I think this data is essential. I look forward to more and more. I think the interesting thing is that collation of data for a state and a health plan. I think it is getting that HIE, that universal HIE, that's pulling all of these data in some form of data lake that's real time, that's claims-based, that we can all access, that's between health plans, between healthcare systems, between states, between providers, and between social networks, social programs, so that this is on-time, real-time data that we can actively engage in. Dr. Rudy, interested to hear your
absolutely.
thoughts.
I just, that's my dream as well. But
Yeah.
you pulled in the social vulnerability index data because we don't get a lot of data sometimes on things like income and so forth. And we did analysis with Medicaid population, and income is already low and equal within the Medicaid population. But we did find things like people who were lonelier also lived in higher poverty neighborhoods. We found that people who are lonelier also lived in neighborhoods where there were more single parents. So it's interesting to see how, those structural factors, those neighborhood factors influence, an individual's loneliness. So we're really utilizing it. We're trying to scale that up more to really bring in more insights as well.
I think this would be a question for both of you. What do you think is a good starting point for health plans that really want to tackle health equity?
I'll let you start.
This is, that's a wonderful question. It's the $1 million question, right? And so for health plans that want to start on health equity, know that you're already doing it. Yeah. Know that much of what you do is health equity, and know that we start somewhere and then we continue, pick up a thread and follow it to the end. And you will be in health equity. I think that for me, the visualization of health equity is that it's not something different than what we're doing. I think there was a question, we were looking within Centene in all of our affiliates, and there was a questionnaire that we filled out as Michigan, where they asked everybody, how many people do you have in your health equity department? So some people had 3 or 4 people, some people had a health equity champion, officer of health equity. And as we sat down and looked at it, we just answered back all 500 of our employees. we are all involved in health equity. So for me, health equity, how do we embark on it? Knowledge that we're already on it, and looking at continuing doing the excellent work we do, and challenge ourselves to then take that work and hyper focus through an additional lens of health equity over all we do to hit those vulnerable populations. Because when we're doing that peanut butter approach, we are giving everybody the same access to our resources, but there are people who need different access and different care. And that, I think that's what health equity is discerning who those members are, and then determining what they need extra so that we close that widening gap on health equity that, by the way, has widened even more after COVID. Dr. Rudy?
That's a great insight, Dr. Judge. I would say for a managed care organization, you can always start with a pilot, like what Meridian did. You need to build your stakeholders to believe in really, investing in reducing health disparities. And I think taking a look in the future helps in that way. So when you think about where CMS is going, are you going to be ahead of the game? I've said this before, or are you going to be scrambling when they start putting dollars behind reducing health disparities, putting dollars behind your quality measures when you see very vast racial, ethnic disparities? So it's really kind of building up the case as well, I think. And, I agree. When I worked in Medicaid, to me, everybody in my department reflected in some ways the people that we served. And so we were so invested in reducing health disparities because that's the passion of working in Medicaid. So you already have this starting point where everybody already is there for that reason alone. It's building then the stakeholder and buy-in on top of it.
That's a good segue into another question we had about what are the steps that you would recommend someone takes to advocate for a program like this within their health systems and, drive organizational adoption?
That's a big question.
It depends on which stage your organization is at. I mean, if you look at behavior change, right? Pre-contemplation, contemplation, right? Action, maintenance. And if your program's in pre-contemplation where they're not even thinking about health equity, or if it's not important, then I think starting to build that awareness is where we need to be. If they're in contemplation, right, like they're already thinking of it, reiterating the need to do it and starting to come up with plans is a way to do. Like organizational change, organization behavior is very much like human behavior change. So in pre-contemplation, I think it's very important to bring out that burning platform. You may have to within your organization. That burning platform is, it's the right thing to do. It is our healthcare imperative. It's why we're all in healing. And there's external factors that we can choose to stand still, but the world is moving ahead, both in reimbursement and in what CMS and the states are expecting us to do. So this is not a choice anymore. So I think if we're in pre-contemplation, contemplation, getting that conversation going in any venue that you can get in your organization. And then I think when we get further into creating that plan and action, then those steps of, methodical, let's start with a pilot, let's pick something, anything, let's try it, and then let's go further.
Yeah, exactly. Build the business case. I mean, today we've presented so much data that shows not only, what the health disparities are and what the social drivers and how it impacts health and health outcomes and cost of care. So building the business case is really important, not only in the return on investment. I mean, that is a big thing. So what does a health plan value? What does your organization value in terms of return on investment? Is it just total cost of care, or is it also member retention? I mean, redetermination is starting up again, right? I mean, that's going to end. And yes, different states are different for Medicaid, but you still want to retain your members. And health equity, how does that play? How does your quality play in. And so I think by looking at all that and then looking at the programs that can impact that, you're really building a really solid business case.
Great. I think that actually leads into one final question that I think is a really good one. What are some of the exciting things that you're seeing happening, innovative approaches beyond this pilot to the social determinants of health equity within the country? What are the things that you're seeing that you're excited about?
Oh, there's so many, and I love that question. And by the way, all the questions have been really wonderful. I think it's just a great conversation. I think that looking at structural systems and how they impact the health, there was a program with Cincinnati Children's and things that we don't even consider that impact the health of children. In Cincinnati Children's, they reduced hospital admissions by 38% by giving legal aid to families. And one would say, what does law have to do with children's admission? But that legal aid was helping them access SNAP benefits and WIC benefits that they weren't able to get. It was letting them sue their landlord for toxic housing conditions. It was letting them contest evictions. Basically keep a roof over their heads. So for me, it's like looking at that umbrella of health and saying, you know, what is actually impacting that health of a member life. That part is amazing. Another one I think is just digital health and where that can go, mobile health and where that can go. Let's bring health to our most vulnerable, to our most socially isolated. Those I find very exciting. Dr. Rudy?
I think really leveraging digital health actually is really exciting. You know, how can you make SNAP cards more accessible digitally? I think is really exciting. I also think, you know, given that I'm, I guess, a epidemiologist data nerd, I think just really, you know, moving the metrics along. I mean, I'm an SDoH organization. My metrics are social determinant of health metrics, and just seeing like how do we get the healthcare community to sort of buy in these metrics and believe in them and understand them. And you know, we're really working on like, what does unhealthy days mean? And so I think it's exciting, just even from a data perspective, seeing CMS saying, we want to see social needs screening, like that will help drive where we go next. And I think it's great that the conversation's that high.
Great. I think that we've pretty much addressed all of the questions. Any parting thoughts, anything that you want to add before we go?
I just want to thank everybody who is so interested that they attended this webinar. I want to thank Dr. Judge. It's just been such a pleasure to share this webinar with you. I'm excited and I'm encouraged that this is becoming such an important topic that, you know, we have this many people attending the webinar.
Absolutely. Thank you, everybody. I'd say let's challenge all of us to continue this conversation. Reach us, link with us if there's any further questions. We're happy to help you along your health equity journey. And I hope this is the beginning of many conversations to come within situations like this. So thank you, everybody.
Yeah, thank you.
Okay, thank you both. I want to thank Dr. Rudy and Dr. Judge for such a wonderful and insightful presentation. Equity was one of our major themes at our last conference at MHPA 23. So we're definitely aligned with you in these efforts. And as a reminder to our attendees, you can see that email down there, hello@papa.com, if you want to reach out to them with any questions. Of course, MHPA will connect you with Papa and our speakers if you have any questions. I know I still have some, but we're at time. So I want to thank everyone for attending as well. As we mentioned, this is one of our biggest webinars. I think there's a lot of interest and for good reason on this topic. And again, thank you, Papa, and our presenters for such a great presentation. We'll see everybody next week for another webinar Wednesday with MHPA. Have a good one all. Bye-bye.